everybody. This is Karen from Caring Nurses. I wanted to bring my friend and nursing colleague Ruth here. Ruth has been a nurse for many years and I've worked with her. She's amazing. We wanted to talk a little bit about how things have changed in the nursing world from when you first started, and you have a very interesting story about how you used to put your nursing cap
Don
on.
myself, yes. Hi there. I've been a nurse for 47 years. I graduated in 1977 from a 3-year diploma program in Philadelphia called Chestnut Hill Hospital. And I have to tell you that when I was choosing my nursing school back then, when I was in high school, we had a lot of guidance counselors and things. Nobody ever directed me to a 4-year baccalaureate program. I don't even think I knew anything about it. So in Philadelphia, just about every hospital had a diploma school of nursing. And I chose the school that I went to for 2 reasons. One, a girl that I played field hockey with was a year older than me, and she went to that school. And then you'd send away for all the catalogs, and I'm pouring through them, and I'm like, oh, I don't like that cap. I'm not going there. I assumed I'd be wearing my nurse's cap for the rest of my life.
Yeah.
And I wanted to pick one that I thought was cute or different.
Yeah.
So I ended up choosing Chestnut Hill Hospital, which
because of the cap.
had the puff.
Oh my God.
With the mother of pearl pin in the back. And actually, this is my original graduate cap. And the director of nursing, of the School of Nursing, mother hand starched all these for us, and that was it. So how you wore it was you put a little safety pin in there, which you can see how yellowed it is, and a bobby pin, and then you had a tissue that you folded, and you took 2 other bobby pins and put it right on the top of your head, which I don't have the other bobby pins, and then you pinned your cap on such. And I'll just put it on, but basically you're looking something like this.
Yeah.
So the year that I graduated, I took a 3 to 11 position as a charge nurse in an isolation unit that was an 8-bed unit. And so that just tells you something right there. I was a brand new graduate, but I was a charge nurse. But I had done my senior practicum there. Yeah. And everybody back then, there were not universal precautions. There was basically, specialized skin and wound, enteric, whatever, bloodborne, whatever. So, different things, different signs, but that cap went in and out of every one of those rooms with me. I mean, you never took your cap off.
Yeah. And did you launder it? Were you able to launder
it? Yeah, you kept it in like a little plastic, zipper case, and it was in your locker, so you never, you didn't wear it outside of the hospital. Okay. And they had come up with ones that were disposable that were made of sort of like same style, but they were made of like almost like a gauze or a crinoline, and they were stiff. Yeah. And like the pleats were already pre-made. Like this, if I take this out, this whole thing opens up and it's a bugger to get back the way. But you would take it, you would use them, and then once they got dirty, you'd throw them out. But this, I don't happen to have any of them left, and this is my original. So, and we had different student caps. Like we had caps that were just a regular standard folded nurse's cap, and then junior year got a black stripe, senior year got 2 black stripes. Yeah. So so that's it. And but like I said, so much of decisions that I made when I was 17 years old were based on what cap I'd be wearing for the rest of my life. And you could tell, like at my hospital at Chestnut Hill, you could tell where nurses went. Yeah. And some of them, like there was one hospital, I think it was Misericordia, that had like a big gold or brass pin that went right through the back of the cap that you would never in a million years want on your body today because of safety reasons. And there was the infamous cap in the Philadelphia area was Philadelphia General Hospital, PGH, which wore like basically a Dixie cup on top of their head with a black ribbon with a ruffle, and you knew the PGH nurses. They were very distinctive, and they were excellently trained. The program had closed after I had gone to school.
So you could tell by the cap.
The cap where people went. Yes.
Interesting.
Yes.
Wow.
Yes.
Wow.
Yeah, that was a big thing. You know, Villanova also, which was a baccalaureate program, I found out after I got into nursing school, had a very distinctive cap too. If I remember, they had like a V on the back, like a navy blue ribbon V. So like, you know, some schools had red velvet, black velvet, blue velvet, depending on where you went. Very few, a couple LPN programs I remember had like an emblem on their cap that would say like Philadelphia School District LPN, because we had some LPNs back then. So anyway, that's my story. And I did bring my little pins.
Yeah, this is really interesting.
And so I did go on to get my bachelor's at Widener University, and my pin says Widener College, but my graduate pin is very tiny. It's smaller. It's about the size of a dime, and it does say on it Chestnut Hill Hospital Training School for Nurses, which was the original name of the school, and it has since become Chestnut Hill Hospital School of Nursing when I went there. And their last graduates were 1981. The school closed. But our we had a advisor, one of the instructors, and when we graduated, she made us all pins, or she got them made. And mine, they all say Miss on them. So mine is Miss R.M. Gindel, R.N. And that was very exciting to get that pin from her, because that, you know, that was before you passed your boards, which is a whole nother story. But she had great faith that we would pass our boards, but we were all Miss on there, because I think there was one girl in my class that was older that was married. She was Mrs. So anyway.
So it's interesting that you got that as a gift when you graduated. I do have to tell you, my marketer, Wade, his mother was a nurse and worked in the ICU. And one story that he has is that when she graduated, she got a special thermometer, the old school thermometer that would be your special one that you keep with you, the old mercury one.
Really?
That, you know, was like a very distinguished gift.
Yes, I know. I was talking to my friend last week about thermometers, how every room had like a little aqua blue plastic thermometer holder with the thermometer, and you know, you'd go in and you'd have to shake it down, and I mean, sometimes if you were standing too close to something, you'd hit a door or something, and then you had mercury all over the floor, which, you know, how safe is that? But you know, you'd play with the mercury, and that wasn't ever a good thing to break a thermometer. But so that's one thing I remember about about many years ago. And to be honest with you, I was telling Karen, I really only wore my cap for maybe 2 years at the most, because I worked med surg, or like I said, the isolation unit, for about a full year. And then I went to a job in the newborn nursery, and in one hospital we did wear our caps. And then I moved to go back and get my bachelor's, and that next hospital I worked in the nursery, we didn't wear our caps, but I did wear it again when I was a baccalaureate student, because I had to do some like, you could pick your courses, but you still had to get a certain amount of credits on campus. So I actually decided to take the med surg nursing course over again. Don't ask me why. And so I was, I was an RN as a student nurse, working 3 to 11 on a med surg floor, and you could wear your graduate cap. You didn't have to wear that school, Widener's cap. So anyway, and I always chose to wear my own if I was going to wear it. But then I worked home care after that. I moved, got married, worked in home care, and we didn't wear, you know, you wore a navy blue suit then, and a navy blue pantsuit or skirt. And
did it feel strange having worn it for so long and then all of a sudden not to have it? Like, did it feel like your head was naked?
Yeah, like you were not hitting things, and you weren't hitting the curtains. I mean, you know, we have so many stories of we as students be in a room with an instructor, and their cap would fly around and, you know, fall off or whatever. You know, I mean, it was really kind of a nuisance. But and another thing, I think I mentioned this before about the narcotics keys. You know, we wore them. They were on a red and blue shoestring. You wore them around your neck, and you know, I didn't know, but the first time I had them on me, and I went to the cafeteria. I still had them around my neck, and somebody came up to me and said, "Oh no, you have to take them off and put them in your pocket."
Okay.
You always kept them on you, but
Yeah.
if you were in the cafeteria where there were, people off the street coming in getting, we don't want to advertise that you have the narcotics keys on you. And I went, geez, thanks. You don't want to get in trouble for something like that.
And then we used to do narcotic count on, in a ledger.
A book,
You'd have to have 2 nurses and you'd have to count everything, and that's all automated now.
It's all automated, right? Yeah. It took a amount of time, and I remember some of the drugs came in a little round thing.
Yep.
That to get it out, you twisted it, and then like the Seconal or the barbiturate drug that you were giving for sleep popped out, or whatever, the narcotic Tylenol number 3 or whatever. And you had to write a slip, and then the slip had to go in a box to go to the pharmacy, and it was a major. And if you were, God forbid, you were off one, it was a major. It still is not a good thing if you're missing a drug, but back then it seemed to be you'd have to go back through all these slips and try to figure it out, where now the Pyxis pretty much does that.
And heaven forbid that you forget that you walk out of the department and get home and get the narcotic
key in your pocket. Right. Yep.
Gotta come straight back.
That has happened, yes. Yeah. So those are some of my memories.
Nice. Thank you so much for sharing. It's been really great.
It's a fun career. It's changed so much when I think back to even the emergency room when I started, 1988. We used to keep, when you said ledger, that's what made me. It was a big book, and it had long pages, and you'd write in the patient's name, what the time they came in, what their diagnosis was, what services they had, like an EKG or an X-ray, and sign your name and the doctor. And you did it according to color. We did the old blue or black for days, green for 3 to 11, red for nights, and it was a big deal. And if you didn't, you had to keep that log updated, And then you'd sit and go through them. We had them, the last couple of years up on a shelf, and sometimes you'd say, "Oh, remember that time?" You'd go back and you try to find it. And now it's that's all obsolete now. I'm sure they've been burned, the ones that we had here, which they'd be interesting for me to go back and look at them. But,
absolutely. But that's a HIPAA violation, of course. Now it's just in a book.
Right. And I mean, there were some days, where we didn't have any patients at night during night shift when I first started. Occasionally you'd had a couple. But now I think sometimes our night shifts are busier than our day shifts. So it's, it's very different, a very different field.
Yeah. You know what? Another thing was brought up was when patients would come to the ER at night and they'd knock on a door.
The back door.
And one of the nurses would go out and say, "Hey, what can I do for you?" And I'm here to be seen.
And there was a buzzer they rang. So the buzzer would go off until the nurse had to kind of step outside and turn the buzzer off. And you have somebody clutching their chest and you're letting them in, but now you're going out. And if that door shuts on you, it was really, that's how it was here for me. And you were by yourself at night, so that there were no secretary. Wow. We called in X-ray. We called in lab. The doctor was here. When I started here, we did have a doctor here, but years prior to me, the doctors were called in from home, and there was a night supervisor who would answer the doorbell and then, call the doctor. As a matter of fact, my husband was on the Peterborough ambulance many, many years ago, predating me, in the 70s. And he remembers coming in with somebody with a gunshot wound. And at night, and the supervisor came down, and she actually argued and said, lifted up the sheet and went, "Well, there's an entrance wound, but there's no exit wound, so it can't be a gunshot wound." He's like, the guy's like, "I'm telling you, I've been shot."
Oh my gosh.
It was a gunshot wound, but the bullet was still inside of him. But it was just, and then sometimes the doctor that came in might have been like an orthopedist or an ophthalmologist who was covering in the ER. They weren't, emergency doctors.
They weren't specialties.
No. And the docs did do 24 hours here when I first started.
Wow.
And up till about, I don't know how many, 20 years ago. When Eric Lasky, he was still doing 12. He did 24.
Wow.
Yeah.
Wow.
So.
That's when they used to be able to take naps at night.
Yeah, right. Which now they don't do at all. They have a recliner back there if they can close their eyes for 5 minutes.
For 5 minutes,
but,
yeah.
So.
Wow. I
So-
feel like we've gone down memory lane.
many, yes,
Wow.
many. So I got a couple more years left in me.
Yes, you do. You better, because we need you.
I hope so.
We
I hope
need
so.
you.
Yeah, yeah. It's nice though. I tell you, work as hard as you can so that at some point you can go per diem. Because now at least I have the, the advantage of being able to work when I want to and also
Yeah.
travel or take some time off. And
Yeah.
it feels like it's been almost 2 years that I've been doing that, and it
Yeah.
feels very good. Although I've had some pay periods where I've worked 60 or more hours.
Yeah. So if you had any advice for somebody who's thinking about going into nursing or who just graduated, what do you think that would be?
I would say to try to get as much clinical experience as you can.
Yeah.
And I think I saw that with some of the student nurses we had here that didn't feel like they were super prepared to go out, and yet all of them, the 3 or 4 that I had, all ended up in the ER and working at Yale, New Haven, and busy ERs, and I think that's the key when you're young, to be able to do that. I did not work in a city hospital ER. I've only worked at this hospital, and as I got older, I knew that anytime I thought about going somewhere else, I'm like, you're not, you just stay in your lane where you know. But I think the more experience you get, the varied. I mean, I had home care experience before I did ER, and you might think they're really vastly different, and they are, but here's the commonality. You're walking into a situation where you don't know what you're going to find.
Right.
And you have to make some decisions. You have to get on the phone and say to the doctor, hey, this person's rails, short of breath. I mean, I didn't have a pulse oximeter or anything like that, but I knew when somebody was in congestive heart failure, and I think we need to send them to the hospital. You have to make some of those decisions. You have to call 911. You have to do a lot of education, which the ER very much parallels that. Yeah. And when I first started in the ER here, one of the nurses that worked here, it was 2 weeks before I was going to be coming down, I saw her and I said, I'm a little nervous. I don't know if I'm going to be able to know what to do. And she said, you'll know exactly what to do. You've been doing home care. That's, that was the other big portion of my nursing career was doing that. And I did that in the city in Philadelphia as well as here, which were, 2 different ball games. But when she said that to you, that made me think, because she said, think about it. When they come into the ER, you have all the equipment. Lots of times the ambulances have done some measure of care before they get there. This is before they were doing IVs and labs and a lot of the things, that they do now. And she said, you're walking into people's homes and the beds don't go up and down, and you don't have chucks, and you don't have, you don't have a lot of equipment.
Yep.
So that gave me a little bit of more I probably can do it. And she's right. And you also have other people helping you, where sometimes in patients' homes, the only other person helping you is a 92-year-old wife or something, you know? Yeah. So, I mean, home care, I'm sure, is much different. I haven't done that since 2003 now, but anyway, I would say get as much clinical experience as you can when you're younger, and diversify and figure out what it is. And the other thing is, and Karen and I are both proponents of certification in nursing, and if you have a specialty, my advice is to try to get certified in it, because it will add, it adds value to your resume, but it also adds value, I think, to your patient care. It teaches you to critically think, and you won't ever regret that you've gotten it. As a matter of fact, you'll become kind of obsessive about keeping it up, because you want to, you want to maintain that, certification through CEUs and other things that you can do that can add to it. So we're both CENs and we're both TCRNs, certified trauma nurses. So.
Yeah. I think, going back to the point that you made about, getting experience, clinical experience, you can be as book smart as anybody, but to actually get in there and to touch patients and to get the clinical experience, it takes a while. And, to take that time to either do med-surg or do whatever specialty you want to, and, know that the book smarts aren't always going to really translate into actually taking care of people. Sometimes it's a hard transition. So the more clinical experience you can get and the more things that you can see and do, the better you're
the more your judgments are sound, and the more, I think the more experience you have, the more you can say, I saw one time, this sounds crazy, but I saw this, and this is looking very much like that situation now. I mean, I saw a patient one time that the only symptom they had was some dizziness, and they were having a STEMI. So I mean, I would never, before that, I didn't always put people, we had 2 monitors in the department, I didn't put people with dizziness on the heart monitor. I do every single time now, unless it's completely like a vertigo thing and they know they have it, and that's what, but even then we'll run an EKG on them, because you just never know. And I would have not thought, just the same as I had somebody years ago who was in their 20s that told me that they had a heart attack, and I'm like, oh, they couldn't have had a heart attack. Well, they did, and they have a drug history and cocaine use, and they had a heart attack in their 20s. So the more experience you have, the more you can rely on things to
I think, that's definitely true. The longer you've done it, the more you know that you can get burned by thinking that you know everything.
Exactly.
And one of the things that I learned is that, if there's a disease that you've never heard of, because it's a very rare disease and somebody says that they have it, one of the most important things that I do is say, I'm not familiar with that. Can you tell me about how you got diagnosed, what your treatments are? Tell me about it. And then you learn from your patients, because they're an expert on their disease.
Exactly. When I have a diabetic come in with an insulin pump, I'm like, I love it, because they know so much and they're so knowledgeable.
Yeah. Or parents with diabetic
kids.
And
you have to give it up to what they know, what they think. Same with somebody that makes a comment about difficult IV sticks. I'll say, well, can you tell me where people typically get them on you? And I take a look, and I say, I'm not going to stick you till I look and see what I have. I mean, this is not in an emergency situation. This is when you have a little time to, to sit down. But patients are often a good barometer, and a person that you really need to listen to. I just had a phone call yesterday with a relative who's 86, who began to tell me her nightmare story of a broken hip that she had in March. This is in Virginia, and got out of the hospital in 4 days, went to a rehab, and developed just some shortness of breath, and they could not figure out what was going on. And she finally said to the nurse, I think I need to go to the hospital. Well, she ended up having a low hemoglobin. She was bleeding from somewhere.
Oh, gosh.
So they admitted her back to ICU, gave her a transfusion, sent her back to the rehab.
Wow.
She said, once again, I said, something's not right. I was there a day and a half, something wasn't right. She said she told one nurse who walked out of the room, and she called her daughter, and her daughter got somebody else. And anyway, long story short, they ended up doing an endoscopy, colonoscopy, went back to the rehab a 3rd time, and had profound shortness of breath. She said, I thought I was going to die. And she ended up having she had a perforation from the endoscopy of a duodenal ulcer.
Wow.
So she was in the hospital from March 27th till May 18th, and then her daughter put her in a different rehab, and she said it made all the difference. But she said, this one nurse, Shannon, wherever you are, she said she listened to me, and she said, something's not right here, and sent her back. And that really drove home to me. I'm appalled when I hear stories like that, that people don't listen to a patient when a patient says something's not right. But I said to her, I didn't even know her name. I said to her, if you know the hospital, and you know the floor you're on, and you know her first name, that's they'll find, if they're going to give her kudos, they'll find her. So I said, don't ever not thank a nurse, because she said, I think that nurse saved my life.
Wow. So long and short of it, listen to your patients. I know that sometimes we get involved in all of the tasks that we need to do, and sometimes we are so involved in what we're doing that, we might miss certain things like that. But it sounds like that particular nurse was really good at what she did, and she went with her gut, which a lot of things we do. So that is the take-home message. Listen to your patients.
Not time to look it up in a book. It's time to listen to the patient. And the thing is, the worst thing that can happen is it isn't something bad.
Right.
But what if it is? And,
Right.
and here's a, a situation
Yeah.
where it was. I mean, it was ironic that we had this phone date yesterday and we're doing this today, but she told me that that whole story. And I mean, she's 86 years old. She's my mom's first cousin, and she's had a cerebral aneurysm. She survived. She said, I've been through a lot. What it was she was on Lovenox. I forgot to tell you about that part. And when she went back to the, after the first time she went back, the physician didn't discontinue it. And the nurses said, kept giving it to her, and she said, "I don't think I'm supposed to be getting this," and then she just continues to bleed.
So listen to your patients and thank your nurses.
Yes, two things. Yes.
Thank you
and
so
be
much.
nice to the old ones, please. we've heard it all, and we've seen it all, and we've been called every name, but you know what? We still keep coming back.
Keep coming back.
And Karen is the next generation, and she's mentoring the younger generation. So we are. We got to keep instilling people to become nurses.
We
That's
have to nurture our young. Definitely.
Yeah, definitely. So.
Thank you all. We'll see you next time.
Bye.
Bye.